Hello, my name is Sheila Sheff, and I'm in the Radiology department at Johns Hopkins Hospital in Baltimore. And I'm going to talk to you today about the role of neck ultrasound in the management of patients with differentiated thyroid cancer. There has been a paradigm shift over the past 10 years in the management of patients with differentiated thyroid cancer, as treatment goals have shifted from disease-free survival to recurrence-free survival. And of course, the optimum treatment for these patients is surgical resection of the primary tumor and any metastases, either at the time of initial diagnosis, if they're there, or delayed metastases. At the same time, we want to minimize morbidity. And there are two recent advantages that have allowed for this paradigm shift. This is the development of serum tumor markers, for example, thyroglobulin levels for patients with papillary thyroid cancer, and high-resolution neck ultrasound. So the objective of this talk then is to give you a very brief clinical background and then discuss the role of neck ultrasound in patients with differentiated thyroid cancer, and I will describe our techniques and protocols. I will describe the neck compartments as they're relevant for surgical management, and we will discuss sonographic findings that help in differentiated benign cervical nodes from potential metastases. Doing this, I will discuss the use of ultrasound in patients after total thyroidectomy first, and then I will also discuss the use of ultrasound at the time of initial diagnosis of differentiated thyroid cancer in preparation for surgery, as I think we are doing more and more of these. So what are the issues with thyroid cancer? Well, in 2008, there were over 37,000 new cases diagnosed, and it seems that the incidence is increasing, probably at least in part related to the fact that we now have better diagnostic techniques, and a lot of these cancers are actually detected incidentally, either on a carotid ultrasound or neck CT. Now, differentiated thyroid cancer account for 90% of these cancers, and of those, papillary cancer, or PTC, are by far and away the most frequent. The management for these tumors is to perform a total thyroidectomy, followed in many cases by radioablation with radioiodine 131, and also TSH suppression with T4 levels, because this not only treats the hypothyroidism, but also suppresses any cancer cells that would be dependent on TSH. Now, while the survival for PTC reaches 98% at 10 years, papillary cancer has a very high propensity for nodal metastasis. At the time of initial diagnosis, 30% of patients diagnosed with PTC have palpable enlarged cervical nodes, and 50 to almost 80% in some series have nodal metastases that are diagnosed either with ultrasound or when the surgeon performed a lateral jugular node dissection. In patients who have been treated for PTC, 9 to 30% of them will have recurrence at some point in the future, recurrence or metastasis, and the majority will have nodal recurrences. Now, all of these, the majority of them are really local regional, so in the neck, and 74% will have nodal recurrences, as you can see on this surgical slide here. 20% will recur in the thyroid bed, and 6% will recur in the trachea or the muscle. So it is very important to have an effective strategy for surveillance and early detection of these recurrences. And once recurrences have been detected, we need an accurate mapping of nodal metastases that allows for optimal surgical planning. And guidelines have been, for management and surveillance of these patients, have been developed by several societies. And while there are very minor differences, they're very, very similar overall. And this is just one reference from the American Thyroid Association down here. I just want to touch on risk stratification. Basically, there are low-risk patients which age at diagnosis is over 16 and less than 45, when the primary tumor is 1.5 centimeter or less, without capsular invasion and metastasis. And there are high-risk patients, mostly older patients above 45, male with larger tumors, over 2 centimeters, extrathyroidal extension and metastasis. And depending on the risk stratification, the surveillance protocol will vary. And again, I want to stress the important adequate surgical resection, preferably at the time of initial diagnosis, to minimize the risk of recurrence. So let's first discuss the detection of recurrences in patients who have had a total thyroidectomy for differentiated thyroid cancer. Now, a protocol will recommend an initial follow-up at 6 to 12 months after the surgery, and then yearly follow-up thereafter. Now, the traditional methods of detecting recurrence that were palpation or whole body scans with radioactive iodine really have been abandoned in favor of tumor markers. And if we talk about papillary cancer, then serum thyroglobulin level is the tumor marker. It is usually done after TSH stimulation. And we all know that thyroglobulin is a thyroid-specific protein, which is a precursor in the biosynthesis of thyroid hormone, and it is only secreted by normal thyroid tissue or functioning thyroid cancer cells, such as papillary thyroid cancer. And of course, after total thyroidectomy, this level, the serum level of thyroglobulin should fall to 0. So it is a very good marker if it starts to rise again for the detection of recurrence. It is also thought that post-ablation serum thyroglobulin level at 6 to 12 months after the initial surgery may be a good prognostic indicator for this patient. However, approximately 15 to 20% of patients have circulating anti-thyroglobulin antibodies, and this marker will not be helpful in these patients. Of course, if we're dealing for a different type of cancer, such as medullary cancer, which arises from the C cell of the thyroid, then we'll have to use a different serum tumor marker, which in this case would be serum calcitonin. The second arm of the surveillance is high-resolution neck ultrasound, which allows for detection of non-palpable metastases and also maps any abnormal node for surgical planning. And ultrasound is actually very good. It has been shown that it has a sensitivity of 94% in detecting recurrence of metastases that can be as small as 4 to 5 millimeters. Other modalities play an ancillary role. Problem-solving cases, neck and chest ultrasound, and FDG PET is also increasingly being used. So when we talk about high-resolution neck ultrasound, there are really 4 main challenges. For the sonographer first, it is a tedious examination that requires patience and fortitude. And for the radiologist interpreting the study, there are 3 main challenges. First, to differentiate benign from malignant lesions. Second, once a malignant or potentially suspicious lesion has been detected, we need to localize them precisely to specific neck compartments. And finally, we are also often asked to prove malignancy with ultrasound of guided fine needle aspiration. So really, this technique requires meticulous scanning technique following a strict protocol, and there's definitely a learning curve. When we were learning this, we made many mistakes, either overlooking some lesions or putting them in the wrong neck compartment, so definitely there is a learning curve. Ideally, you want to correlate them with the serum tumor markers I talked about, and a physician monitoring the study should really be involved very, very closely, rescanning any problem cases. And finally, there needs to be an effective communication with the referring physician. So let's first describe the central compartment of the neck, which is located here between superiorly the thyroid cartilage, inferiorly the sternal notch, and laterally, and this is a very important landmark, the common carotid artery. So the central compartment is located between the trachea and the common carotid artery, and it contains nodal groups 6, 1A, which is above the thyroid cartilage and is much less commonly involved. And these level 6 nodes include pretracheal, paratracheal nodes, which are the most commonly involved in metastasis or recurrence, and superior mediastinal nodes. The lateral compartment, as you can see on this diagram, is located lateral to the common carotid artery, and the superior boundary is the mandible, and the inferior boundary is the clavicle. And again, the important thing is this medial boundary, which is the common carotid artery. So the lateral compartment is lateral to the common carotid artery, and it contains nodal group 2A and 2B, which are the submandibular/submental nodes, but also the jugular nodes, which are level 3 and 4, and more laterally, level 5. And while the distinction between level 3 and 4 is not that important, what is really important is that it is lateral, again, to the common carotid artery. So this is just very briefly our scanning protocol. We obtained transverse images from the mandible all the way down to the sternal notch, and then laterally to the clavicle. And we also obtained sagittal measurements to this level. And without going into detail again in all these landmarks, the most important thing is, again, that your landmark will be the common carotid artery to differentiate the central compartment of the neck from the lateral compartment of the neck. And while, of course, we use a high-resolution, high-frequency linear transducer to image the neck, it's very important to complement your scanning with a sector or curvilinear transducer and angle below the clavicle as low as we can and below the sternal notch as low as we can to try to detect these very low-hanging metastases potentially. So this is a clip showing the central compartment of the neck. This is the clavicle here. We go back up the carotid artery. Here's the central compartment, and this patient actually has a little metastasis on that side. On the left side, of course, you will also see the esophagus posteriorly, as you can see here. And then this clip shows the lateral compartment of the neck. So again, here medially, you'll see the common carotid artery, and anything that's in that area is in the lateral compartment of the neck. And again, we scan from the angle of the mandible all the way to the subclavian vein and artery. Now, a picture is worth 1,000 words, and we always give our referring clinician, endocrinologist, as surgeon, a diagram which is composed of a frontal view and 2 lateral views, left and right, and we mark all the abnormal nodes in their specific compartments as we see them. So let's talk about first central neck recurrence, mostly level 6 here. So the normal postoperative appearance of a central compartment of the neck, you see the common carotid artery that's very, very close to the trachea. There may be no tissue at all or a little bit of echogenic tissue. And if we see any mass in this compartment, then to me, it is a suspicious mass until proven otherwise, because since the patient has had a total thyroidectomy, there really should be very little tissue in that compartment. As you can see in this patient, there is a large mass displacing the common carotid artery away from the trachea. This mass has microcalcifications within it. It has increased vascularity. This patient was a patient who had a total thyroidectomy for papillary thyroid cancer 2 years prior to this ultrasound. He came with an elevated serum thyroglobulin level as 131 nanogram per milliliter, and of course the fine needle aspiration confirmed that it was a suspicious metastasis for follicular variant of PTC, and the surgery confirmed this finding. This is another patient who actually had a total thyroidectomy for presumed papillary thyroid cancer that was done somewhere else 14 months prior to the study. And he presented with this mass, which is located in between the common carotid artery and the trachea. Notice that this mass is hypoechoic. It is taller than wide. It has increased vascularity. It is on the corresponding neck CT, a hypervascular right paratracheal mass. And this was done at fine needle aspiration, and in fact, it was a metastatic medullary carcinoma, so perhaps the initial surgery was wrong, and the surgery confirmed this diagnosis. Now, this recurrence can be very small. As you can see in this patient, there are two small, somewhat lobulated hypoechoic masses, one on the right, level 6, one on the left, level 6, and despite their small size, they are suspicious because they are somewhat lobulated in shape. They have perhaps tiny calcifications. This patient also had positive finding at PET, and again, this was proven metastatic papillary thyroid cancer. This recurrence may have a cystic component, which should really not dissuade you from calling this suspicious. And this was also a recurrent papillary thyroid cancer. Now, there are mimics of recurrence. Not all tissue in the thyroid bed is going to be metastatic disease. For example, this patient had a large mass displacing the trachea, the common carotid artery away from the trachea, and this was at biopsy residual thyroid tissue. You can have scar tissue, suture granuloma, muscle tissue, fat necrosis. These are all cytologic diagnoses that were found in this series from Shin et al. Published in 2007. And of their level 6 lesion that underwent FNA, 20 out of 59 were malignant, and the other one had a variety of other benign diagnoses. Now let's move to the lateral neck compartment that includes level 3, 4, 2, and 5. And in this compartment, the challenge is really to differentiate benign cervical nodes that are very, very common from malignant nodes. So what are the characteristics of a benign cervical node? Well, it should be oblong or oval in shape. It should have an echogenic hilum, and this node has a very prominent echogenic hilum, which is a central fat. But however, this can be difficult to see if the node is very small. And if it has vascularity, it should be central and somewhat sparse. Really, the size of the node is not helpful. And contrast this to this malignant node here. This is very clearly malignant. It is round and lobulated in shape. Its long axis to short axis, if we measured it, would be less than 2. There is no echogenic hilum. The echo texture may be hypoechoic or very heterogeneous compared to the surrounding muscle, and you may see punctate echogenic foci, as you can see here. You can also see cystic changes, and if you turn the Doppler on, this will have irregular vessels. Here's another example, smaller node, but notice the cystic changes, and this actually has very high specificity of 100% to diagnose metastatic papillary thyroid cancer. However, the sensitivity is very low. And it's interesting to note that while the primary tumor with papillary thyroid cancer is very rarely cystic, their metastases tend actually to have more cystic changes. Another characteristic feature of metastasis would be these hyperechogenic foci, which may represent either microcalcification or colloid. And again, this sign has a specificity of 100% and a sensitivity of 46%. Same patient, different node. Again, hypoecho, very, very hypoechic, partially cystic, punctate echogenic foci, and if we turn the color on, increased disorganized sort of vascularity. Again, that is metastatic disease. Now, does the size matter? Well, this patient had a thyroidectomy for medullary cancer, and when we scan her, we see this node, which is very small. It's less than 1 centimeter. It's in the lateral compartment, but it's round. And she also had an elevated serum calcitonin level, so we biopsied this lesion, and FNA, this was metastatic medullary cancer. In fact, nodes as small as 4 to 5 millimeters can harbor metastatic disease. So what's important is the shape of the node and possibly its location. If you have a lesion like this in the central compartment of the neck, I definitely would also be very suspicious. Now let me show you a few challenging cases. This was a young woman which had a history of papillary thyroid cancer. When we scanned her left neck, central compartment here, lateral compartment here with a linear transducer, up and down, we really did not see very much disease. It's only when we put the curvilinear transducer and looked very low just above the subclavian vessels here that we found this round mass, which is of course very suspicious. It is heterogeneous in equitexture, and this was metastatic PTC. So it's very, very important that in all cases we remember to change transducer and look low. Another challenging cases. So this patient was diagnosed with PTC a year prior to this examination, and we saw this node. So the first question is, when you look at the transverse, this is the right side, so the trachea is here. Here's the common carotid artery. It is anterior to the common carotid artery, and so it's at level 6 or 4. It's difficult to see, and what I say in these cases is I say it's level 6/4, but I tell the surgeon that it's anterior to the common carotid artery, and this surgery is usually much less difficult than nodes that are deep in level 6. The other question when we look at it is that it seems like it has a fatty hilum. However, this node stood out in this patient. It was bigger than the other ones, and we also knew that he had an elevated serum thyroglobulin level, so that he had to have some metastatic disease. And when we turn the color on, you can see that there's only peripheral but large vascularity here. And based on that, we recommend that the patient had a fine needle aspiration that confirmed the diagnosis of PTC. And peripheral vascularity is actually a pretty good sign of malignancy. It has a sensitivity of 86% and a specificity of 82% in that study by Lobulo and al. That I quoted earlier. Another challenging case, now this patient has a lymph node here. It is in just anterior to the common carotid artery on the left side, and on the transverse view it doesn't look that ominous. When we look longitudinally here, there is a fatty hilum, but however, there's a portion of the node here that is more lobulated in shape, perhaps a little bit more hypoechoic than the rest of the cortex, and we won't turn the color on, there is increased vascularity in that area. So it's a very subtle but real suspicious recurrence, and when we did the fine needle aspiration, we made sure that we target this area specifically to prove that this node harbored metastatic papillary thyroid cancer. Another challenging case, this patient had bilateral lymphadenopathy on the right level 4, this node which is oval in shape, hypoechoic, but has no fatty hilum, and is actually almost 1.5 centimeter. He also had a smaller node in left level 4, but if you look at it, there is a fatty hilum, but again, it's very eccentric. So based on this, we decided to do fine needle aspiration of both these nodes, and this turned out to be just a reactive node, but this harbored metastatic medullary thyroid cancer. So there are some nodes that I will not be able to put in any category. They're not definitely benign, they're not definitely malignant, and I will call that indeterminate. Here's an example. This is a patient who has multiple nodes. He has a chain of nodes. They're kind of round in shape. There's some increased vascularity maybe. Certainly they have no fatty hila, and so I would call this indeterminate. And while the patient did have a recurrence in another area in the central neck on the right side, we biopsy these nodes which just prove to be reactive. So there will be a category of indeterminate nodes. We also have to keep in mind that level 2 nodes that are submandibular tend to be larger, rounder in shape, may not have as clear a fatty hilum, and these rarely harbor metastatic disease from papillary thyroid cancer anyway. So if these are bilateral, I just tend to discard them and consider them normal. We see these kind of plump level 2 nodes in many, many patients. So now let me discuss the role of pre-thyroidectomy ultrasound. Now we know that up to 50% or maybe more patients would, at the time of initial diagnosis for papillary thyroid cancer, have cervical node metastasis at presentation. And while these nodal metastases rarely affect survival, these patients are prone to recurrence that may occur in up to 30% of the cases. And So ideally, you want to remove that at the initial surgery because macroscopic nodal metastases may not be adequately treated with radioactive iodine. So the current recommendations then is to do a preoperative neck ultrasound in all patients at the time of initial diagnosis prior to their initial surgery to detect potential nodal metastases and map their location. And preoperative neck ultrasound will then provide optimal guidance for management, and the decision from the surgeon to perform a lateral compartment neck dissection will depend on the ultrasound findings. They will only do a lateral neck dissection if the preoperative ultrasound is abnormal. There is a lot of controversy regarding central neck dissection. Some surgeons do it systematically, some don't, and that's because when the patient still have a thyroid in place, ultrasound has a relatively low sensitivity of only 22.6% in this very recent study for detecting central compartment metastases. Nodes that are in the thyroid groove along the recurrent nerve can very oftentimes be obscured by when the thyroid is still in place. So let me show you a couple of examples. This is a 53-year-old patient who had a very heterogeneous mass replacing almost the entire left thyroid lobe. And note how extensive nodal metastasis. This is on the left lateral level 3. Extensive multiple adenopathy in the lateral neck, very hypervascular. And of course, these patients will have a lateral radical neck dissection at the time of his total thyroidectomy. Unfortunately, he also had a small, what I think is an abnormal node on the right side. It's abnormal because it has cystic changes, tiny bright foci, a little bit of increased vascularity. And although this is a very recent case, I don't have proof of it. I'm very suspicious that this patient will come back to us to have fine needle aspiration of this node and will at some point require a right neck dissection as well. Here, another patient in which preoperative neck ultrasound changed the management. This patient had a relatively small 1.1 centimeter papillary thyroid cancer in the right lobe of the thyroid. And when we did the full neck ultrasound, there is a level 3 node, it stood out because it looked a little bit more cystic. We could not really see a fatty hilum. And while I was not ready to call this suspicious, I definitely called it indeterminate. And based on this, the patient had a fine needle aspiration that showed metastatic PTC. And he ended up having, in addition to his total thyroidectomy, a right radical neck dissection. Now, we are oftentimes asked to do fine needle aspiration when we found abnormal nodes, and I briefly want to show you our setup. We use a needle guide technique here with a transducer and the needle guide covered with a sterile cover. I use local anesthesia in all patients, and we use 25 gauge needle with capillary technique. And we are fortunate at our institution to have a cytopathologist on site that will give us immediate feedback regarding adequacy of the specimen. Now, there are some challenges associated with this technique. First of all, oftentimes these recurrences are very small, located adjacent to major vessels. But I think that since we use very fine needles, such as 25 gauge needle, this is probably okay. The rate of complication is minimal. Another perhaps more important question is, well, how many nodes need to be biopsied? And the answer is, in every compartment of the neck, if there is an abnormal node, it needs to be biopsied. So for example, if the patient has bilateral lateral compartment neck biopsies, I will biopsy the right and the left. If the patient also has central compartment recurrence, this will be biopsy also at the same setting. So patient may end up having 4 different biopsies because our surgeons will not go and undertake this sometimes very challenging reoperation. There's a lot of scar tissue, a risk of morbidity, unless we prove by fine needle aspiration there is metastasis in that node. There has been some new development recently in the fine needle aspiration technique. Some pathologists suggest that in addition to cytologic evaluation, measurement of thyroglobulin concentration in a needle wash may improve sensitivity and specificity for diagnosis of metastatic node. And at least in this study, it was suggested that a cutoff of 1 nanogram per milliliter of thyroglobulin in the wash be used to differentiate benign for potentially malignant nodes. And of course, this is only valid if the patient does not have any circulating antibodies. So to conclude, I just want to give you some numbers for ultrasound. This is from a Mayo Clinic series. And when they look at the reoperative patients, or patients who had total thyroidectomy in the past and were coming for potential recurrence, they found that ultrasound detected non-palpable lateral compartment nodes in 64.2% of their patients and non-palpable central compartment nodes in 28.2% of the patients. And in fact, ultrasound provided additional information that altered the surgical management in over 40% of their patients. For the preoperative patient, the patient that came at time of initial diagnosis, again, there were non-palpable lateral compartment nodes detected in slightly over 14% of their patients, and so there was ultrasound gave additional information that altered the surgical management in 40.5% of their patients. So in conclusion then, the current management of patients with differentiated thyroid cancer has a high emphasis on high quality neck ultrasound, and this is a quote from that Mayo Clinic paper that I just mentioned that said anatomic precision in the dictated report is vital information for the surgeon. Ideally, you really need a multidisciplinary team that is comprised of endocrinologists, surgeons, radiologists, sonographers, and cytopathologists to handle these patients. Communication is incredibly important. The sonologists need to understand what the surgeon needs, give diagrams to the surgeon depicting the abnormal nodes, and in difficult cases, we will help the surgeon by doing preoperative marking of the nodes on the skin just prior to surgery, or even if the surgeon has difficulty finding nodes, we will go in the OR and help the surgeon with intraoperative ultrasound.